Okay, good evening, everyone. My name is Rita Fleming Castaldi, and it is my privilege this evening to be presenting Therapy Ed's online office hours. They are held every Tuesday from 7 to 8 p.m. Eastern Standard Time. And during these sessions, we focus on content that we know is tested on the MBCOT exam because it's specifically identifying the MBCOT content outline. Tonight, I will be covering medical, community, and school based practice settings and what are the considerations for that you need to know to be able to select correct answers for your MBCOT exam items. And at the end of this, I will also have time for open-ended questions that anyone may have about effective certification exam preparation. I am Rita Fleming Castaldi, and I have the privilege of having worked with Therapy Ed for, since 1998, when I first started working on the first edition of the textbook, the review and study guide. And I just see there's more people in the waiting room. And we are now in the 10th edition for the OT Review and Study Guide and the 5th edition for the OTA Review and Study Guide. But my background, I've been a therapist for 45 years because I am 67. I graduated with my bachelor's degree because that's what the bachelor's was back then in the late 70s, what OT education was. And through the years, I worked in community-based practice, acute mental health practice, transitional programming, and then in academia. But I stayed very involved with different settings through consultation and also my brother who had Friedreich's ataxia. So his lived experience kind of became my experience. So I have a consumer perspective of settings and also a practitioner educator perception of settings. My area of research is in empowerment and enabling people to live in environments of choice. That also relates to this regarding self-directed personal attendant care and recovery and empowerment models. So I also will be talking about models that are consistent with the different settings. And before we can begin, I'm going to do a few logistics. This information is copyrighted, and as you will see, I have a number of screenshots from the review and study guides, which is protected by copyright. So we do ask that you don't do any recording, video recording, screenshots, use of Quizlet. If you do it for your own personal, particularly if you're using it as an accommodation for yourself, that's no problem. But once you post it on public domain, like Quizlet or Instagram or Facebook, it is a violation of copyright law and our profession's ethical standards. So I thank you for complying with those standards. Okay, I have muted everyone to decrease distractions. Do turn on your mic if you have a question or concern. Based upon past sessions that I've held, people have asked, so some people do need to leave a little before 8 or right at 8. So they've asked that I save all questions till the end. So I will honor that request and save all questions to the end. That being said, the caveat is if, say, I said something too fast and you didn't understand what I said, please feel free to just unmute yourself and say, Rita, wait a minute, what did you mean by that? Because sometimes when you know something through personal experience, professional experience so well, you may say something rather quickly and not realize it may not be common knowledge or easily understood. So please do if I need to clarify. But other questions, please wait till the end. And also I may be covering that information in a subsequent slide. The other thing I ask is do scroll, particularly we get a number of questions, to see if your question has already been asked. This will decrease repetition and allow for more diverse questions. So what is our focus tonight? As I said when I first came on, when if just a few people were here, we're going to be reviewing what is must-know content that must be mastered to answer certification exam items about medical, community, and school-based practice settings and the role of OT in those settings. Now, the MBCOT exam is not going to ask you, what's the role of OT in acute care? What's the role of OT in the school? They're not going to ask you those types of questions, but they will include questions that have a setting in the item. So your correct answer requires knowledge of the setting. And what I will be reviewing is in chapter 4 of both the OTA and the OT review and study guides. Now, if you have the 5th edition and the 10th edition of the review and study guide, in the OT review and study guide, this information begins on page 83. In the OTA, the review and study guide begins on page 81. If you have the 9th edition or the 4th edition, just go to the table of contents, look up chapter 4, and the sequence of the chapter will follow. Will just be off a number of pages. Okay. So why are practice settings relevant to the MBCOT exam? Basically, MBCOT exam is designed to measure the depth and breadth of OT practice. So therefore, the items measure that broad scope that we work in many different settings. Each item then does contain information related to tasks, skills, and knowledge. That's the MBCOT content outline that MBCOT is determined is essential for safe and competent entry-level practice. That's what the exam tests. And you could go to www.mbcot.org and look at the content outlines for the OTR and the code exam, and you will see what are the things they say. So each question, though, will ask you just about a specific aspect of one of those tasks, skills, or knowledge. For example, the best intervention for an OT practitioner to implement for a specific diagnosis in a specified practice setting. They may add the practice setting, because how you treat someone with a TBI or spinal cord injury in acute care is very different than how you treat someone with a TBI in long-term rehab, in home care, or in a transitional vocational living program. The focus is going to be different. Now, this information, I will talk about this when people said about boot camp before we started. That's the therapy ed course, where we spend 2 days for the OT exam, 1 day for the OTA, going through what is must-know content, but doing a lot of practice on taking exam items. When you take that course, you get a course manual that basically walks you through the review and study guide. And this is an example of a manual statement related to setting. So it will say, for example, you need to know, and this is a direct quote from the manual on page 6 of both of these, where it sets up what you need to know for the exam. So answering exam items that identify a specific setting means that you need to know, what is the setting's typical models of practice that they use? What do they typically use? What is the typical length of stay? What are the typical characteristics of setting? And what are the typical needs of the population that tends to be served by that setting? Do know the MBCOT exam will only ask typical things unless they say there's an outlier going on, because they're not testing exceptions to the rule. They're not addressing the complexities of someone who has a TBI because they had a car accident and has alcoholism. They would have to add that extra. MS, when a person has initial exacerbation and is maybe seen in an outpatient clinic, the likelihood of them having cognitive issues that need to be treated is going to be low. Can that happen? Yes, but cognitive issues in MS typically is later on. So it would be after the person is not getting their first OT intervention in an outpatient MS clinic. So understanding the typical needs, models of practice, length, stay, and characteristic of setting will help you select correct answers to the exam. Let me make the next person. Okay, so because sometimes you may be more familiar with one model versus the other, in both the OT review and study guide on page 125 and the OTA on 123, I have a table that goes through the service delivery models. So know that your correct answers to MBCOT exam items that include a practice setting will be consistent with the service delivery model that is typically used, as I just said. So for example, biomechanical approaches is a better medical model, and a medical model is used when someone has a hand injury or an upper extremity injury. So you would be using biomechanical approaches in a hand clinic. In a partial hospitalization program and in many outpatient programs, you use education models, okay? Because you're teaching people to manage your illness and be aware of the symptoms, maybe through like a cognitive behavioral therapy type of approach, okay? Learn how to reframe, okay? So that would be a psychoeducational model using an education model. Now, I'm not going to go through all the points on this slide because they are in the book, but knowing how does the model view the person with a disability, what is their primary focus, what does the intervention address, and what are the typical frames of reference. So again, in medical model, we're curing, we're remediating. In education models, you are increasing knowledge and increasing health literacy. And I will have a slide about health literacy in a couple minutes. Okay, I have it right now, actually. I updated everything for the new book. So health literacy, that's where the education model really comes in. And it's very important to know that this should say, excuse me, guys, this should say the OT. I'm going to change it right now so I don't forget. In the OT review and study guide, there is the same. Oh, wait, no, I'm sorry. I should not have done that. It is below. Okay, let me just correct that. That was the OTA page. I apologize. Okay, so this is OTA page 61. I don't want to keep going back and forth. And the same requirement is in the OTR exam on page 63. Okay, so this is from the book for the code exam. But basically, on both exams, they say that you need to know strategies for addressing enhancing health literacy with client and relevant others. That is a standard for both exams. So therefore, all the information that we provide in chapter 3 about learning principles and teaching methods, okay, and the specific information about health literacy that is identified in chapter 3 can be applied to determining correct answers, okay? And chapter 3 includes information about education, training, health literacy. And again, table 4.4 that I just showed has about the education model. And you know that health literacy is emphasized on the exam. The other two models that are in this table is the community model, where we are looking at connecting the person and the skills they need to live in their chosen community, and what are the resources and supports they need, and how do you help the person engage in occupational performance within those communities. So this is where you get more into lifestyle performance, occupation adaptation, model of human occupation. Now, important thing to know about the telehealth model is telehealth can be delivered both from a medical framework, from a rehab framework, from a educational framework, and from a community framework. You know, telehealth can be used in that manner, like from community doing telehealth with people who are living in the community at an MS support group. Okay. They can be synchronous or asynchronous. So you will have items on the MBCOT exam that recognize the potential of telehealth to attain treatment goals. And again, that is something that we have in the manual. Okay. So the other thing to know is that in these models, and particularly related to telehealth, the MBCOT specifically says you need to know, and this is true this is in the OTA Review Study Guide 122 and the OTR 125. You need to know how to select, prepare, adapt intervention environments for optimal engagement and promote goal achievement. Okay. And one of the things that's included in that standard is privacy during telehealth. So this exam hint is emphasizing you need to know your privacy acts during telehealth, like how HIPAA applies. And basically all of the, regardless of service delivery models, has to be HIPAA compliant. Now, chapter 4 in both the code and OTR exam goes through HIPAA. But do realize when you're looking at settings, the laws that govern those settings, such as HIPAA in all practice settings, IDA in school-based practice, OBRA, which is a restraint reduction in nursing homes, those will all apply. Okay, telehealth is in our CODA review and study guide because it is a standard. So I'm pretty sure it was in the prior edition on the models of practice in chapter 4. It was not in this table format. Okay, it was in a narrative. For the difference between the 4th edition and 5th edition for the CODA and the 9th edition and 10th edition for the OTR exam is that I was able to put a lot more information into tables because I had the gift of time to do that. So this information was in prior editions. I do know that. I don't know the page number. I'd have to look it up for prior editions, but it is in the current edition because it is required on the exam. Okay, so relevant to practice settings. Another thing to know about practice settings related to the exam is we use different terms to describe people when we work with them in different settings. Where services are delivered will often depend on the terms that are used. So these language differences may be reflected. You may have a question about an inpatient hospital, and the item will use the term patient. You may have a group home question, and it will include the term resident. Or a skilled nursing facility may say resident, or assisted living may say resident. A school has the term student. A clubhouse, they would be a member or a consumer. Okay. Now, throughout, they may just say a client. Okay. But if you hear these terms, do know that is conveying, the way the person is viewed within that model. Okay. The medical model settings, there's a lot. So there's no way I'm going to go through all of them. So I'm going to go through three of them tonight just to show you how they're outlined in the book and give you an understanding of how the book succinctly organizes this information for you. So in the 10th edition, it's 126 to 127, OTA 123 to 125 is where the medical model settings start. And those include acute care units in hospital, long-term acute care, and rehab hospitals. These are the three I'll go into more detail, which showing you this type of information. But for long-term care hospitals, subacute, intermediate facilities, and skilled nursing facilities, all of the settings in the textbooks are described as far as the reason for the person being admitted, what is the typical length of stay, what is the typical evaluation focus, it was the typical intervention focus. So that information crammed into those 4 pages. So acute unit, the good part about these, they give you hints about what they're about. So acute unit means the person's acutely ill. It's an initial onset of illness or an acute exacerbation of illness. So it's initial onset of, a stroke or an acute exacerbation of MS or schizophrenia. Someone's acutely ill and it can't be treated on an outpatient basis. And that's the key. Now, length of stay is usually only a few days, 3 to 4. Longer length of stay requires justification. Now, you may have a question about that, that's saying, person is being prepared for discharge, but in the item, it may say the person is exhibiting during OT some cognitive issues. What should the therapist do? It may not be referred to home care because if the person's discharged and you don't know the nature of the cognitive issues, you don't know their safety level, that would not be safe. So it may be advocate for extension of LOS to evaluate cognition. Okay, so that's the key with acute care. But for the most part, if there is a need for further treatment that does not compromise the person's safety, it will be discharged either to home or to another setting. A partial hospitalization program in psych, a skilled nursing facility, long-term acute care, or rehab hospitals. People go to other settings once they're stabilized. The evaluation process has to be quick because you only have sometimes 24 hours to 48 hours. Sometimes evaluation, one session, maybe 2 sessions. So they're the major difficulties. What was the key with acute care? Remember when you had a question about acute care evaluation, it is what is the main thing that lets that person being qualified to be hospitalized? Because remember, people are not hospitalized for unless they have something that needs acute care. Okay. So what are the things? The client factors, the performance skills, home, safety, pain. Okay. Those are the things. And is there a question of the person's competence? So that is the key thing about it needs to be quick and focused on the main reason for admission. The occupational profile, I know the occupational profile is very important and obtaining the full occupational history is important. The likelihood that's not going to be attained in acute care. You don't have the time. But you may, on screening, ask what is the most important thing for you to be able to do for you to go home? What is the most important thing you do at home? What's the thing that gives your life most meaning? So targeted assessments, either those open-ended questions that really target the most important thing to engage them in treatment, or using the goal assessment scale, which is specifically developed for acute care to get the person engaged in their goals. The role checklist, if you're not familiar, all these tools are described in the book. But the role checklist is fantastic, 1 page, double-sided. What roles are important, what roles people have done can really help you target into what the person is important to them so you can help them understand how continuing treatment will engage them. There was a really good article in OT practice about 10 years ago where a therapist who basically only had length of stays of 24 to 48 hours because she basically was an OT who worked with people post tendon repairs. So if they stayed for a very short amount of time. So she used the role checklist to help them understand why they had to do what could seem like boring exercises to engage in the activities they found meaningful, like gardening or playing board games with their kids. So the role checklist is a great acute care item. And then the Allens is one that's often used for screening in acute psychiatric care or in skilled skill is long-term care, but in acute care, the Allen's cognitive level screen 5 is often used. And it's basically the evaluation process, figuring out what are those self-determined goals and what is the big priority. The focus is stabilization. Again, if we have acute care, we want to stabilize and to stabilize that crisis that contributed to the admission. The big part about acute care, and I worked in acute care for a couple of years in psych, and I loved it until I moved into community. If you can get, and that's the goal. So therapeutic rapport and developing a therapeutic relationship can be a correct answer. Because if I can engage the person in that therapeutic relationship so they can see that change is possible, look how much you accomplish in 2 days. Imagine what 2 weeks of partial hospital can do for you. That is a success. Okay. The models of practice, though, are the ones that address those presenting symptoms, whether it's biomechanical, neurophysiological, Allen's, CBT, sensory modulation, whatever is the model that fits that the reason they came into the acute care. Okay. And then discharge planning from day one. That's a strong characteristic of acute care. Discharge planning begins day one. What is going to be the most relevant discharge that enables the person to continue in their recovery and maintain safety? So that could be to clubhouse and psychosocial, or partial hospital psychosocial, home care in both mental health or phys dis, or into a rehab hospital, skilled nursing facility, as I previously mentioned. A big focus is also on discharge planning and consumer education, and that's where health literacy comes in, both the family and consumer, to maintain safety. Now, in post-hospital, to address the presenting behaviors and motivate the person to engage in post-hospital, there is, again, as I mentioned, proactive therapy yourself, learning how people can adapt their activities, how to modify the environment. That's a very important part of consumer and client family education. People, though, have psychiatric and or neurocognitive disorders. Sometimes they present with symptoms that can be very challenging, say like delusions and hallucinations. Okay. That is where knowing how to address challenge behaviors are important, both in practice and on the exam. For example, if someone is having a delusion, by definition, they're false, unshakable beliefs. So we're not going to confront it and say that's not real. We're going to redirect them into a concrete activity and remove them from environmental stim that may be escalating their symptoms. So we de-escalate, we don't confront. In both the OT review and study guide 483 to 485 and the OTA 454 456, there's information about multiple challenging behaviors, from delusions and hallucinations to monopolizing behavior to manic behavior to people who are difficult to engage. Okay. For long-term acute care, it took me a while to wrap my head around this because when I was practicing, this was not a common thing, but it is now common now because of the advances in medical technology and changes in reimbursement. So it is, because long-term and acute seems like an oxymoron, but this is when someone still has acute illnesses that require hospital-based care, a lot of tubes, okay, intubation, but it's going to be a long-term issue. So there's now special units and special hospitals just for long-term acute care, because the acute care hospitals have to have turnover because more people are coming with crises and exacerbations. So this is for chronic or catastrophic illnesses, like say someone does have a stroke, but they're not recovering. Okay. And they can't go to rehab and they can't go to, skilled nursing facility because their medical needs are so significant, or someone traumatic brain injury, but whichever diagnosis, so significant, they need skilled 24-hour medical care. So they need that medical care, or they're dependent on life support ventilators. Okay. So that's what their admission is for. Also, multiple diagnosis, major complications. Length of stay is often greater than 25 days. And the evaluation and OT evaluation intervention can be limited by the severe and complex medical needs. When someone is, basically on a lot of medical support and life support, it really is about preventing complications and palliative care. So OT may go in to do more positioning to prevent decubiti and contractures. Okay, and that may be a primary focus in long-term care, is preventing complications, preventing deconditioning as best as possible. If someone's able to walk holding something, okay, and maybe do something sitting up. If people are alert, because sometimes many people in long-term care are not alert and able to engage, that's when maybe it may be mastery of that environment around them. So what is something they can do bedside that is meaningful to them? Okay. And then long-term hospitals and intermediate care facilities and rehab hospitals, just like it says, rehab and long-term, it means we're here to still rehabilitate, okay? To do things that is still rehabilitating. Oh, Tarek, I would like to ask you at the end to maybe share your experience about it, because firsthand experience is always good. It'd be good to know. But let me get through this, and I would welcome hearing your experience as fieldwork in long-term acute care. So long-term care, not where they have acute needs, where someone is stable. So it is for medical psychiatric diagnosis, progressed from the acute stage, but not stabilized sufficiently to go outpatient or to go home. Okay, and this includes more in-depth assessments. This is where OT can really get into very long-term, a full occupational profile, a complete COPM, an executive function performance test. You can get into much more in-depth assessments. And this is then looking at, because you want as much information as possible in long-term care and rehab, as much information as possible about the person's current status. And then as they improve, it's a lot of reevaluation. So what are the functional improvements? We want to improve their performance skills, their areas of occupation. We want them to get involved. This is where, again, goal attainment scaling is really important. Take what came from inpatient and you look at that and say, how can we help you along the way with that? And engage them throughout the process. And then figure out what is the expected environment. Is the person going home to live independently? Are they going to transitional housing, group home? Are they going to need to go to assisted living? What is their expected environment? And you make sure that your treatment matches, that they have the skills they need for that expected environment. Okay, every Thursday, Therapy had posted an exam item of the week, and it's about the content that's being covered on Tuesday. The answers are provided on Sunday. So this is the one that was posted this Thursday. Now, if people want to review this and just think about the things that I just talked about, long-term acute care and the other settings, if people want to say, based upon the knowledge you acquired, what would be the correct answer to this? And if you put this in the chat box, what is the correct answer? Or someone wants to unmic and shout it out. Okay, hold on. Let me now look to make sure I have the correct answer. Patrick, you are correct. Why did you select A and reject the others? You can unmute.
Honestly, I just remember the answer from seeing the question before.
Oh, you need to go a little louder, or maybe my volume is off. Hold on, maybe my problem. Let me make sure my volume is up so I can hear people when they talk. All right, Patrick, good. Let's try again. Thank you.
Because A is the only one that makes sense. It's prevention, for long term, with complications like decubitus ulcers forming and the length of stay being
Right.
as it is. You want prevention and treat. Prevention is primary focus.
Yeah. Yeah, and you're right. This is one that matches the focus of acute care. Now, I did see people put in, C, and I understand that because acute presenting problems, and that is the next closest, but it's not exactly correct because the person, once they go into long-term acute care, they have been stabilized, but they need that ongoing treatment for that issue. This is the function of acute hospitals, just acute hospital without the long-term care. Functional improvement is for rehab and long-term care hospitals, and compensatory strategies would be more for some, also part of rehab or long-term care, when there's something the person is not going to be able to improve on. So what are the strategies you're going to be able to use in your expected environment? Okay. Yes, the other one is are for other settings. You're exactly right. Okay. So again, to reiterate, long-term care provide long-term acute care. Hospitals provide care for patients with chronic or catastrophic illnesses or disabilities, require extensive medical care, or dependency on life support or ventilators. Prevention, treatment of complications, wounds, contractures, primary focus of OT. Yes, it would be C, to go back. If it said acute care, not long-term acute care, the answer would be C. Okay, so C is for acute care, basic acute care, where someone has an acute crisis or an exacerbation or a new occurrence of an illness, and the other two are for rehab or long-term. All right, now I want to talk about school, community-based. Okay. I'm only going to cover schools because there's so many community-based ones, but I just want to highlight the number of settings that are included in the textbook, and they go from page 128 in the OT up to page 133 and 126 in the OTA. up to page 135, I'm sorry, up to 135, so 128 to 135 in the OT, 126 to 133 in the OTA. So we cover EI, pre-voc and voc, residential, including domestic violence shelter and things like halfway houses and group home, partial hospitals, day treatment and clubhouse programs, adult daycare and home health, and case management, wellness, and prevention, and health promotion, I should have said. And again, in each of these, we'll talk the reason for admission, the length of stay, evaluation focus, and evaluation intervention focus. So for example, transitional employment programs and halfway houses are both time limited, 3 to 6 months, 2 to 6 months, 2 to 4 months. Group homes is a permanent living situation. There is no LOS. It's where someone can permanently live because they need that ongoing support. Whereas a halfway house, you develop skills to live independently, so you don't need it for the rest of your life. Supportive employment is the same. I need that ongoing support to maintain myself in competitive employment. Whereas the TP is, I get to the point where I don't need that support. So those are subtle differences, but those are things to know because when they ask you, say, which type of setting someone should be discharged to, or what is the best plan for someone for vocation, know the length of stay because it should match the person's functional ability. So these are the ones that I cover in the chapter. And now I'm going to talk a little bit more about schools. Because sometimes I've been doing the courses now for many years, and sometimes in school-based practice, students, there's a lot that we know about schools, but sometimes in programs, they focus on one aspect of school-based practice and sometimes not on the older child, okay, and transition in high school. And they also sometimes, in some settings, if you did school-based practice, I know for my students, some settings, focus more on just the academic and not the other aspects of school-based practice. So I want to let you know the NBCOT exam and in practice you should be aware of. The focus of OT practice in school is not limited to child's preparation, participation in educational activities only. In fact, the law now was in 204, where IDA was amended, so 20 years ago, to say that the child's functional performance and their future performance in education, employment, independent living are also mandated focus. So correct answer on an NBCOT exam about someone, a therapist or an OTA working with a student in elementary school or preschool, a correct answer could be helping the child learn to don and doff clothing so they could independently go to the playground, take their coat on and off, and toilet independently. That could be a correct answer. It could be teaching the child adaptive strategies for self-feeding so they could feed themselves in the cafeteria. It could be adaptive strategies for play so they can engage in research, or recess. So do know that the correct answer could be about functional performance, and that's been true since 2024, that IDA mandates that. The other thing in transition planning for middle and high school planning, it's about future education, employment, and independent living. So you could have transition program questions, and it could be about doing a travel training group to take public transportation, say if it's an urban-based school. It could be about how to do laundry sitting from a wheelchair, how to make notes for myself to remind myself about my medication management. So it could be really anything, which is the really exciting part about school-based practice. I have a number of friends and former students who've worked in school-based practice, and high school and middle school is just so much fun because it covers all of OT. So it has expanded. And this is what IDA covers, okay? Future education, employment, independent living, functional performance. Now, also know that in many schools, the role of OT practitioners has expanded beyond IDA to give related services to include programs that address students' psychosocial needs. And that began in efforts post-Columbine to prevent violence in schools. There was a number of initiatives and grants that came out post-Columbine for looking at how occupational therapy could address psychosocial health in schools. And many of those programs have continued to this day. Some have ended, but there are a number of schools who do adopt these strategies. And one main strategy that OT service provision could be included in is school-wide positive support system, okay? So, and response to intervention and early intervening services. Now, RTI is actually in also an amendment to the IDA. So RTI is part of IDA. Positive behavioral support system is not specifically part of a IDA because that's for the whole school. And IDA focuses on the individual, says Individuals with Disability Education Act. So IDA is the individual. So that includes all this up here, functional performance and response to intervention and early intervention, intervening services. School-wide positive behavioral supports is a school-wide thing, but many schools, when they really know the value of OT, engage OTs in this process. So you may have questions about that, and your correct answers will reflect that foci and require you to apply the tenets of school-wide positive behavioral supports, response to intervention, and early intervening services. And I know from my course, sometimes these terms aren't familiar with people. So I'm pleased to say that we added significant amount, and this was written by and compiled by an OT who is an OT educator who actively works in school-based practice. Okay. No, quick question, Emily, I'll answer. There is no certain percentage upon academic. And in fact, there should not be. The IEP should be based upon what are the things that are most important to enable the students' participation in the school environment. My handwriting may not be the most important thing because I can use a computer or I can record my answers with that adaptation. However, my participation in the lunchroom with my peers or in recess may be most important. My ability to dress so I don't have to have an aide follow me to the bathroom may be most important. So the IEP should be based upon what is the most important things for the student to be able to engage fully in the school environment. That was a great question. I appreciate that question very much. All right. So school-based positive supports. Okay. Is a program that is designed to create a positive school environment to improve the behavior, emotional level, social, academic outcomes for all students. So it's not just to single out students who are having difficulties, who are problem children, who have behavioral issues. It's meant to create an environment that enables everyone to do well. And there are the clear tenets and consistently communicate expectations, teach positive behaviors through strategies, consequences for handling things that are misbehavior, identify positive behavior. So it's all about the culture. And there's a number of examples here, but this is where OTs come in really handy because we understand how to adapt environments, we understand how to modify environments, we understand how to identify those little steps towards positive behaviors, those little changes, and say, yay, So it really is a very positive thing that if your schools don't have it, it's a great thing to advocate for with your school board. But the other thing, it is something that be aware, this could be a very correct answer for an OT being part of doing that in schools. And we did add a couple questions to our practice exams about this type of approach. And then RTI. It is evidence-based, structured, multi-tiered that uses early intervening services to address academic difficulties and positive behavioral supports to behavior problems. So this is focused on academic and behavioral issues, not so much the ADL issues and like the play, leisure, occupation-based issue. And it is where, you go in and you can do, so RTI, I kind of misstated, I was focusing on these intensive interventions because for the longest time, RTI was basically focused on this, the one-to-one, of going into the classroom. And the good thing about RTI with individual kids is you don't have to have a whole IEP evaluation. A teacher can say, hey, this kid's struggling in the classroom, and an OT or an OTA can go in and assess the child and see what are the needs that the child has with sensory processing, emotional regulation, is it visual stim, and then say, how can we help them regulate? So this is where and it's like just doing a couple interventions that can make a difference. So an example that is often used is by giving a kid who has, they have a need for a lot of vestibular and proprioceptive input. Okay, that's their sensory processing system. They have a need to do this, to give them one of those chairs that rock or a ball to sit on. And then once they have that, they're good. Kid who is fidgety, give them a fidget toy and they're good. And there's no need for further intervention. So when I said to the individual child, I was actually focusing on tier 3. It has now expanded into schools more often about screening, to just making sure that like kind of everybody knows. So everybody, how do you open lunch containers to decrease the frustration? How do you practice them? And then target intervention in classroom. Okay, so you do what a targeted group. So there are the 3 tiers. The one I was most familiar with is tier 3, but now this RTI is getting integrated more fully into schools. And it ties in right with the positive behavioral supports theory. Okay. So in conclusion, successfully answering exam items will require you to understand the settings model of practice, length of stay, characteristics, the needs of the population, which then relates to OT evaluation and intervention. So if you just learn the needs, you can figure out, well, if my need is this, like, managing that I'm not delusional, then it's about, that, some medication management, also helping the person, you know, engage in, reality oriented tasks. If something is about someone, having to recover from a hand injury, what is the need of that? What's the evaluation focus? What's the intervention focus? Now, my advice is don't over memorize the content in the chapter. There is a lot of details you can see from those screens, and that is for every setting. Instead, what I suggest you do is look at the description and take a minute. This is good for study groups too. You can kind of almost do a Jeopardy or like a quiz thing with each other. What does it look like? Think of acute care, a lot of hustle and bustle. You think of home care, someone in their own living room. You think of schools. You think of long-term acute care. Things a lot slower and a lot of medical equipment. Okay. So what does the setting look like? And then who is there? Is the family there? Are teachers there? Are fellow consumers there? Are a lot of medical staff there? Okay. And then why is the person there? Is it for stabilization? Is it dealing with a chronic problem? Is it for developing functional skills? Is it learning to become independent for adult life? So why is the person in this setting? And what is being done in that setting? What is typically done? And why do they leave or why do they stay? So like kids leave school when they graduate or they turn 21. Okay. Someone leaves acute care when they're stabilized. Someone leaves transitional employment programming when they have the skills to be able to be competitively employed. Someone stays in supportive employment because they need those ongoing supports. So just like do that talking to yourself to get a sense of the setting, because your correct answer to the item will rely on your knowledge of the setting, but also your knowledge of the diagnosis. But you have to make sure that your answer is pragmatic in the setting. And the example I always use in my OT courses, exam prep courses, is say someone with MS. You have someone with MS and it says they're a parent, a gardener, and a home maintainer. And one of the answer choices is raising, and they're a wheelchair user, raising flower and vegetable beds so they can garden from the wheelchair. A fantastic answer. But if it says acute care, it's not the correct answer because you can't do that in acute care. It's going to be triage. It's going to be what is the precipitant that brought the person in. The balance is now off. And they've tried, they don't use the wheelchair. They only use the wheelchair for outside the home. And they had a fall in the home while toileting. So now we got to look at what are the issues that we can build as far as is there conditioning issues, but also maybe what are the adaptations they need in the bathroom and home. And maybe they need to look at what are the strategies in the home for functional mobility in the home. And plus dealing with the sequela of the fall, if say the person hurt themselves, which is why they would be admitted because if someone fell and they didn't have an injury that required hospitalization, they would not be admitted for a fall. So knowing that type of information, it will help you have the correct answers to NBCOT items about settings. All right. Are there any additional questions about settings? Because then I want to review a few resources for you. And I can open up questions and also ask
I have a
this
question about
Yes,
setting.
go for it.
Is there somewhere to find like which settings do home evaluations? Because I've noticed there's some questions where there'll be an inpatient rehab and one of the choices will be to, do a home evaluation or an assessment by some method. And I didn't know if outpatient does that as well, or school or things like that.
Good question. It's going to be one of the answers that's frustrating. It depends how the question is set up. But say you have that someone is acute care And there's actually a question, of course, about this, and they expressed concerns about safety in the home. Say this person with MS that I just said that had a fall and they're hospitalized because they broke something, they broke their hip or something, so they're hospitalized, but they're going to be going home, and there's concerns about safety in the home. Having that, one of the things the therapist does is a home evaluation would be critical, because you can't say refer to home care, even though we would refer to home care. But home care will take anywhere from 48 hours to 2 weeks to come. So you want to at least get a preliminary screening of the home. And you could do that via giving the family member a home safety checklist, okay, or having a fieldwork student. Now I'm getting to complexities that, wouldn't be on the exam, but they wouldn't set it up too complex, but giving a family member a home safety checklist and asking them to take pictures of some key areas like the bathroom, like the bedroom, how high
Okay.
is the mattress? So that would be key. Now, if someone's being discharged from acute care, they're cognitively intact, they have no functional mobility concerns, there's no real pressing safety things, then a home evaluation would not be it. It would be more discharging them. In school's a tough one because it's about participation in life. So I'm having trouble right now thinking of a time where an OT would do a home evaluation in school, but I could see, on the exam, but I could see in real life, and maybe you would get a situation like this where a kid's getting ready for, graduation or in his transition programming and wants to be more independent in the home, and they have XYZ disability. And it's like, okay, let's analyze the tasks in the home the kid can contribute as far as maybe home management. What can the kid physically or cognitively contribute to the home because they, want to practice at home. But that would probably be more you not going to the home, because that probably would not be pragmatic in most school districts. But it could be having the parents and having an IEP meeting where you modify the transition plan to include some homework, because you do homework in the home related to that IEP goal. So does that make sense?
Yes, I think maybe the key is if the question's asking, like, insinuates that we need more information, then think about an evaluation of some sort. But
Yes.
if it's, we already know what's wrong and what we need to work on, and then of course, differentiation between OTA and OT roles. So all the
Right.
factors.
Yes, that does come in, but you're right. There should be some indication in there that there's a need for evaluation. You're exactly right. If everything seems status quo and things that were, need to be addressed have been addressed, then it's okay. What's the next stage in the OT process? We've ended this process, this setting. Now what's the next stage? Now with the OTA and OTA role, do remember that the OTA can contribute to the evaluation process by completing evaluations. The OTA does not determine which evaluation, and the OTA does not interpret the evaluation independently, but they can perform an evaluation with the supervision of the occupational therapist. So correct answer could be that, the therapist assigns the OTA to work with the family on evaluating the home by doing a video call. That could be an acceptable answer. Particularly, a very important thing to pay attention to with OTA, the role of the OTA, particularly with evaluation. If it says the OTA is service competent, if it says an OTA is service competent in home evaluation, or it's a service competent occupational therapy OTA, that means that the occupational therapist has determined that the OTA can do that eval and get the same results as if I did it myself. So those are some key things. So the OTA role does add a bit of complexity, but it would be perfectly acceptable if it says that with supervision, the occupational therapist has requested that the OTA complete the home safety checklist and do a video tour of the home with the family prior to discharge. That could be a correct answer. It could be a correct answer. Good questions.
Thank you.
But does the
Yes.
OT, sorry for just randomly barging in, but
No, go
does
for it, Todd.
does the OT have to be present when the OTA is conducting this eval?
Nope. Nope. Now, no, not at all. not at all. Now some states, let me clarify this, you may have some states and facilities that require that. Okay, so if you saw that in practice, let me clarify very clearly, is because I know he was kind of adamant about that, but it's not required by national standards. Okay, it's not required by AOTA standards and what is the national standard for the role of the CODA, which we have really good information about that both in chapter 3 and chapter 4 and throughout both textbook throughout. But you know, but some state laws may have that. I don't know a state because I'm like in the Northeast, so I know Massachusetts, New York doesn't have that, but because those are the two states that I've been licensed in and the two OT associations I belong to. So I only know New York and Massachusetts well. But there could be some states that do require. I know there was an issue quite a while ago about line of sight of the CODA. It was a Medicare thing. That for a CODA to be doing certain things, the OT had to have line of sight. And that was with students actually, come think of it. It was with students. They need line of sight of students for everything. And that caused a lot of problems in many programs, particularly in acute care, because if a student's been a fieldwork student for 2-3 months, do I really need line of sight if they're doing, some ADL activity in the kitchen with someone, teaching them how to use rocker knives and things like that. And I know the student is competent in that. Do I need line of sight? But that was removed a number of years ago. So that line of sight thing may still be in some places because they feel for liability or whatever. So you do always have to follow your facility guidelines for sure to keep your job and your state guidelines to keep your license. However, on the exam, the standards of what is considered the scope of practice of OT and OTA is what's followed on the exam, because the MBCOT is a national exam. State can't cover state issues. So according to our standards of practice, the key word is with supervision. So it has to be set up of thank you, Emily. Yes, the book has levels of supervision, and that's an important point I was just going to go into. It has to be set up that says the occupational therapist is supervising a CODA. And it should say something like, to complete a service competent CODA or CODA with, 5 years of experience. Or, it should give some indication that indicates that the CODA, that the supervisor is doing competent practice by saying the CODA can complete this evaluation. It should not be, the correct answer would not be that the CODA independently determines which home evaluation to use or which safety evaluation. Do they use the SAFER? Do they use that? That would not be the role of the CODA. It would be that the occupational determines the evaluation. And it should not be that the CODA completes the evaluation with the family and then makes the decision and revises the treatment plan accordingly. That would not be correct because the CODA cannot independently revise the treatment plan. So there are those subtleties.
Got it. Thank you for clarifying. And
No worries. Good questions. Good questions. And then
Yeah,
if it does say, go ahead, Todd.
sorry, I was just gonna say like one last thing, but it wasn't gonna have to do with what I just asked. It was something on the slides. So you go ahead, you like finish it off and then I'll ask.
Okay. All right. Good enough. All right. I just want to remind people, for those of you here earlier, you heard people talk about the boot camp. And that's basically the certification exam preparation course that Therapy Ed runs. The important thing to know that, and this is really important for everyone, that there are 2 aspects to MBCOT exam sets. One is knowing this content. Okay, knowing this content. But then as per the questions that were just asked, it's how do I figure out the correct answer? What is that nuance that makes one choice more correct than the other? Because all 4 may look correct. But when you have 6 options, 5 out of 6 may look correct, but I'm only supposed to pick 3 correct because only 3 are correct. And that's where the course comes in, or the boot camp, as a number of students said. Each course does give you correct information about the current MBCOT exam, so you fully understand what's required to pass, kind of like I just said about national versus state and facility guidelines. We do emphasize active learning throughout the course. You are taking questions and then we're reviewing them and going back and saying, what was the clinical reasoning? What was the critical reasoning to break down to get the correct answer? And what are the strategies used to break down and determine those correct answers for the type of exam items on the book? Important thing to know, if you have the book, the course fee already, you get credit for owning the book. If you don't have the book and you register for the course, you do get the book. You can get it either in print or electronically. And it does have that manual. And I had a couple screens that had, some quotes from the manual in there. And it basically is a roadmap that walks you through the book. And the really cool part in the manual is that it will give you study hints, kind of thing that I just said, like don't memorize, make a picture of the setting, and numerous self-assessment and exam preparation forms. There are many things you can get online for doing it, but we have found through over 24 years of exam preparation that when people individualize their preparation for themselves, it's much more effective. Because what I struggle with is different than what you struggle with, is different than what my friend struggles with. Do make sure though, if you don't have the book, do not buy from Amazon. There's a person who buys our books and sells them, and they seriously inflate the price. So the best price is at Therapy Ed. And also if you buy from Therapy Ed, you can get group discounts, you get a group of students, and you can also, if you do decide to take the course, you will get credit for buying that book. They are on campus and online, and they are taught by people who've been OT and OT educators for decades and who have done exam preparation for decades. If life happens and you thought you were taking the exam in July, so you took the course in June, and life happens and you have to delay your exam until December, Therapy Ed does allow a free retake of the course to get a refresher. And say life happens, unexpected circumstances, and you don't pass, you are also allowed a free retake of the course. Because sometimes the second time, it kind of rings more true to people. Do know that the review and study guide, as you can see, it really is efficient. It covers all the information you need in one textbook. Okay. That is tested on the MBCOT exam. Those exam hints are throughout the book that relates to the content outline. And they are the only single purchase product. There's a lot of things you can buy and spend a lot of money, which is why it's more economical to buy the one resource, because it has all you need to know. But also at the end of every content chapter, which is 3 to 16 in the OT review and study guide and 3 to 15 in the OTA, there's chapter review questions at the end that help see, do you remember some key information from this chapter, to just give you that jump start on studying. The other really important thing is it does have a lot of information on test taking and time management, so you can pass the exam in a lot of time. But most important, and why it really is effective and economical, is it gives you access to 3 full-line online practice exams. 3 exams that mirror either the CODA exam or the OTR exam, depending upon your book. And they're made to simulate. So you get 12 hours of practice. And of course, you can use extended time if needed, if you have a disability. And you get very individualized practice score reports that tell you the content that you need to study that directly relates to the book. So besides the 4 MBCOT domains, you get 9 content categories that relates to the chapters in the book. So like biomechanical versus neuro versus cognitive versus developmental versus psychosocial. And then the really cool part, besides the score report, you get information about these very comprehensive rationales that then link you to have an AI learning assistant that provides answers to frequently asked questions about the exam focus, such as diagnosis or treatment. And that gives you an opportunity to also ask additional questions. And access to that score report, those rationales, and the AI remains for 12 months. So you get a lot for your one purchase of the book. And here's a screenshot of this. This is a question. Oh, oops, I'm sorry. This was a question about someone about a PNF question, okay, diagonal patterns. So I didn't copy the question because it's from the book, but I just wanted to show you how it tells you what the correct answer is, why this is the correct answer based upon the item description, what type of reasoning. And then it tells you what were the correct answers, the incorrect answers. And then you can click on these and you could say, what are some other neurophysiologic approaches? How does Parkinson's disease affect rotation? Can you explain the concept of inferential reasoning? I never heard of that before. You click on that, the answer pops up both from our book and other reputable textbooks. And then you could ask your own questions about, tell me more about PNF. What else does PNF do besides diagonals? You can ask those types of questions. And this is for all of the exam items that you take for the exams that are associated with review and study guide. You get this level of detail and this level of resources. So that's why you don't have to be, spending a lot of money buying other things or, getting, PDFs. They're also, with Every Ed, does offer a mobile app that allows you to basically for 12 months, and you can use it on Android and I'm not an app person, so this is for those of you who are app people. But a lot of students find it very, very helpful. It is a 12-month plan. It will include any future updates as they add more questions. These are the items from the review and study guide, but additional items are added as they are developed. But they are a way where you can, take these and you have access to the portal with all those explanations on your phone, and they can be filtered. So you could say, I'm really weak in neuro. So I just want to take category 4, and you'll get all neuro questions. Or you could say, I'm really weak in evaluative reasoning, and you just get questions with evaluative reasoning. So you really test your knowledge in items that you identify that you need more preparation. Say you take our practice exams, you feel you're a little weak in something, you can pull these back and test yourself forward and you can track your progress. The other resource I want to talk about is, as you know, from you're here, we have our online office hours, and they follow just what I said, 60-minute session where we have a targeted review of must-know information, and they follow them by open-ended questions, and up to 500 people. Now, sometimes we get 120 now post-COVID. Last week I had like 75, but a couple weeks ago. But during COVID, we did get up to 500 people attending these sessions. And then there is tutoring. If, say, you are extremely, anxious about the exam, or you've struggled with the exam, Therapy Ed does have tutors. They are fee-based. They're not free like the online office hours or the exam item of the week, but they are individualized. And the one thing about Therapy Ed that I'm very proud of as a company is they will not contact you trying to sell you more tutoring sessions. It is totally student directed. People are preparing for the exam. They schedule it online on their own. How many sessions? And many of the tutors say that usually sometimes people only do 1 or 2 sessions just to get on the right track. And these are our topics, okay? And we do a 26-week cycle. The thing to know about these sessions, they are recorded and they are posted on Therapy Ed's YouTube channel within 2 weeks of the session, and they remain online for a month. But a lot of times they remain longer than a month because, to be honest, the person who manages YouTube does it on a part-time basis. So they will be up in 2 weeks, but they'll remain longer. The online session webinars that are permanently available, they don't get removed, is the application of mindfulness to certification exam preparation. I did a session both about the 2024 exam for the OTR and the 2024 exam for the code exam, frequently asked questions. Those are up there. Effective exam preparation. And these are different webinars I have done related to I did one recently for the Tennessee OT Association and Minnesota Student Conclave, AOTA Student Conclave. So these are different things that you may find helpful. Webinars. If you found this office session helpful and think other students can benefit from knowing about this free resource, please do feel to comment on social media, and also maybe share your perspectives on AOTA's Facebook page. Those of you who thought the boot camp was helpful, as you call the course, that would also be great. Okay, I apologize. The person who said, where were you in chat, who said you worked on long-term acute care? Are you still here? Because I would love to hear your perspective.
Yeah, I'm still here.
Oh, great. Tell me what your experience was. And did I
Well,
do
first,
okay with my explanation?
yeah, first of all, my experience was a little crazy. It was like during COVID. So
Oh,
yeah, so it was what was it 2021 on there?
right.
That
Right.
summer, December 2021. One thing I do wish I could have did, because I had to do my level 4. My level 1 field work was done on the computer. So with a SimuCase.
Right.
So like I wish that part would have been, I wish I was able to do that part in the field. Like I wish, like honestly, I wish like I was able to, like, I feel like all my field works should have been prep. Like my field work 2, I should have been at the place at field work 1. So it's like a preparation of what you're gonna be getting into.
Right. Yeah.
So like my
Yeah.
first day of field work was at the last. Like that was my first field work. So it took a while to get used to like all the plugs and everything. So it took a while for me to get used. You know, you don't want to touch anything. You don't want to mess
I know.
anything up.
Yeah. It's a very intense environment. And it is, it will be on the exam, but a lot of people, there's conversation about it that, how much do we teach entry level students? Because it's intense.
Yeah, and I
It's
almost felt like a
intense.
nurse.
Yeah,
Like
Yeah.
like just like all the stuff you had to know like beforehand. Like like so I would go there like 30 minutes early because I to go get my sheet who I have with patients who I have, and I go look up all the cases, look up the whole profile, and just to figure out what precautions I need to do or work out for.
Right.
And like my schedule was based on their schedule, so I would see whether or not okay, which one has wound care in the morning. Like someone had wound care in the morning, and someone had wound care and they have dialysis. So I'm like, okay, they're not gonna after dialysis, they're not gonna want to do anything. So
Right.
let me just get them ready for wound care. Like so I have to like schedule like that and just like it was a lot. It definitely was a lot.
That, yeah, that's a challenging situation. And
Uh,
COVID was definitely provided so many challenges to field work,
yeah, and
Um,
I feel like
yeah.
I got and then like also like I feel like I got the patients like nobody really wanted to go near to. So it was like, oh, give it to the new guy. Or give it to the so it was like that part too. And I do wish like I do wish I did more what's it called? I can't think of the name of it right now. Oh my god, I can't think of the name right now, but like helping patients sit up and get like sit up and stuff like that. More transfers. I wish I
More
did more.
active treatment. Yeah.
Yeah,
Yeah. More active
because
treatment. Yeah.
it's kind of hard. It's easy to do transfer on a well body. Like that's so like we practicing doing transfers doing all your courses stuff like that. That's the easy part.
Yes.
Like
Particularly
doing
with
it,
cooperative fellow students.
yeah.
Your fellow students are going to be cooperative. Yes.
You know what I mean? So it's like, can I do one transfer? It's like I'm nervous, she's nervous. It's just like okay, this is not gonna work if we're both nervous.
Well, I am glad you came out of it well.
Yeah,
And I hope that, you may want to consider, one day, some places may allow you to do like, a shadowing thing or just even be careful about picking your first job. Make sure it's in a place that there are some places that are really, really good with having, mentorship for new therapists and new OTAs.
yeah, that's what I heard. Heard
Yep,
like
there
pretty
are
much
some. So
yeah, everybody was telling me like you just might have just had a rough
You
start,
did, yeah. Oh, for
but
sure. There was a very rough time. I would definitely say be selective about your first job, even if it may be economically a little scarier. But what you learn from a job that has where they have good mentorship and they have like good, staff training, it will pay off in the end rather than like in a place where you're on your own from day one. Because being on your own from day one, you lived it in COVID, you don't want to
yeah,
repeat that if at all possible.
yeah. I think my because I'm besides studying for the test, like I'm a paraprofessional, so I worked in the school base for a while. Like I worked right now I'm in the public school, but I worked in a private school for years. So it's like I've seen the difference between OT in a private school and OT in a public school. OT
Mm,
in a private school, I noticed, but we someone they focus a lot on like all like the ADLs as far as like focus a lot on ADLs, and whereas like private public school, they focus basically like on education, like
yeah,
pencil, like all you grip writing, handwriting, and stuff like
right.
that. And like they don't really focus on like a lot of bathrooming because a lot of people are not comfortable doing those things. And with
And I think that has a lot to do with the comfort level of the therapist, which is I always try to make that point because the therapists that I do know who I said have been doing this very function based OT, they're all in New York State and New York City public school system. And the New York City public school system, many of the schools are very active in doing very assertive approaches, the
yeah,
subways and so really depends upon the school board,
yeah,
the principal, and the therapist. So really it requires a whole school initiative to get that focus.
yeah. It really requires like when I went to public school, I just feel like certain like I work with kids with autism, so it's like certain things I realized like some of these kids are missing out on. Whereas though they was at a private school, they get a lot more attention, but also you got that part of it that's business wise. It's like they don't public schools don't really want their kids out because that
Yeah.
costs money that taxpayers have to pay. It's like
Yeah.
97 grand right there, and they're there until they're what 21. So it's like they got that aspect of like, well, we can do like,
Yeah.
but no, it's like it's hard. It's a lot
It
hard.
is. It is. Change is hard for people. Okay, change is hard for people, that's for sure. But you know, there are people making some really good changes. So I wish you the best in connecting with some of them.
Yeah,
Really, thank
definitely.
you. Thank you for sharing.
No
Um,
problem.
does anybody else have any questions about exam preparation? I did see a question in the box about an exam item, so I'm going to stop the recording because I don't like to discuss exam items on. Stop recording. Okay, having trouble finding that. Hold on, everyone. Oh, there we